The single most dangerous mistake people with high blood pressure make is not eating too much salt. It is not skipping exercise. It is not even forgetting their medication. The most dangerous mistake is treating high blood pressure as a number to manage rather than a biological emergency that is actively damaging your heart, your brain, your kidneys, and your arteries every single hour. It remains unaddressed at the root level. And the reason this mistake is so deadly is that high blood pressure produces almost no symptoms while it is doing its worst damage. You cannot feel your arteries stiffening. You cannot feel your heart wall thickening. You cannot feel the microscopic damage accumulating in your kidney tissue or the changes happening in the blood vessels supplying your brain. By the time high blood pressure announces itself with a symptom you can feel, the structural damage has typically been building for years. My name is Dr. Darius Coleman. I am a senior healthcare specialist with 16 years of clinical experience working with adults over 55. And what I am sharing today is not a replacement for your medical treatment. It is the biological context that most physicians do not have time to deliver in a standard appointment. The explanation of what uncontrolled hypertension is actually doing inside your body right now, why the standard approach leaves the majority of patients with blood pressure that is managed but never truly resolved, and what the one correction is that changes the entire trajectory. By the end of this video, you will understand your blood pressure in a way that makes every recommendation you have ever received finally make complete sense. I want to ask you something specific before we go further, and your answer genuinely matters. Has your blood pressure been consistently elevated despite taking medication and following dietary advice, or has it been fluctuating, sometimes normal, sometimes high, with no clear pattern? Drop your answer in the comments right now, because those two patterns reflect two completely different underlying mechanisms, and Dr. Coleman addresses both of them in this video. Here is what high blood pressure is actually doing to your body, and why the damage is far more specific and far more serious than most patients are told. Blood pressure is the force that your blood exerts against the walls of your arteries with every heartbeat. When that force is consistently elevated, when the systolic number stays above 130 or the diastolic above 80, the arterial walls are subjected to mechanical stress that triggers a cascade of biological damage responses. The inner lining of the arteries, called the endothelium, is a single-cell thick layer that regulates blood flow, prevents clotting, and produces nitric oxide, the compound that keeps arteries flexible and dilated. When blood pressure is chronically elevated, this endothelial lining becomes damaged. It loses its ability to produce nitric oxide efficiently, the arteries become stiffer and less responsive, and the damaged endothelium becomes a site where cholesterol and inflammatory particles begin to accumulate, forming the plaques that narrow arterial channels and set the stage for heart attack and stroke. This process is called endothelial dysfunction, and it is the reason why high blood pressure is the single leading risk factor for both cardiovascular disease and stroke simultaneously. It is not that high pressure is hard on the heart in a general way. It is that elevated pressure specifically destroys the biological machinery that keeps arteries healthy, flexible, and open. And once that machinery is damaged, every other cardiovascular risk factor becomes significantly more dangerous because the protective endothelial barrier is no longer functioning properly. After age 60, this damage accelerates for a specific and compounding reason. Arterial stiffness increases naturally with age as elastin fibers in the artery walls are gradually replaced by less flexible collagen. An older artery has less natural resilience against elevated pressure than a younger one. The same blood pressure reading that causes moderate endothelial stress at 45 causes significantly greater structural damage at 65 because the arterial wall has less capacity to absorb and recover from the mechanical force. This is why the blood pressure targets recommended for adults over 60 are not relaxed compared to younger adults. They are equally stringent, and in high-risk individuals, more stringent, precisely because the consequences of inadequate control compound faster with age. The kidney damage from sustained hypertension follows a similarly insidious pattern. The kidneys filter approximately 180 liters of blood per day through a network of tiny blood vessels called glomeruli. Elevated blood pressure damages these vessels progressively, reducing the kidney's filtration efficiency over time. As kidney function declines, the kidneys become less capable of regulating fluid balance and electrolyte levels, which in turn makes blood pressure harder to control, creating a feedback cycle where hypertension causes kidney damage, and kidney damage worsens hypertension simultaneously. A study published in the Journal of the American Medical Association found that adults with uncontrolled hypertension had a 240% higher rate of significant kidney function decline over a 10-year period compared to those with adequately controlled blood pressure. 240%. From a single modifiable risk factor. The brain damage from chronic high blood pressure is perhaps the least discussed and the most consequential for quality of life. Elevated pressure causes small vessel disease in the cerebral circulation, the network of tiny arteries supplying the deep white matter of the brain. Over years of elevated pressure, these small vessels thicken, narrow, and eventually become occluded, cutting off blood supply to small regions of white matter and producing the microscopic brain injuries called white matter hyperintensities. These lesions accumulate silently and are visible on MRI scans in the majority of adults over 70 with a history of poorly controlled hypertension. Their clinical consequence is the progressive cognitive decline, the slowed processing speed, the memory retrieval difficulties, the reduced executive function that most people attribute to normal aging, but that is in a significant proportion of cases the direct neurological consequence of years of elevated blood pressure damaging the brain's vascular supply. Now let us address the one mistake directly, because naming it clearly is what makes the rest of this video actionable rather than theoretical. The mistake is treating blood pressure as a medication management problem rather than a vascular biology problem. When blood pressure is treated purely as a number to be lowered with medication, the medication does its job. The number comes down. But the underlying vascular biology that is driving the elevation continues operating unchanged. The endothelium continues to be dysfunctional. The arteries continue to stiffen. The inflammatory processes driving vascular resistance continue. The medication is suppressing the measurement without addressing the mechanism. And this is why the majority of adults with hypertension find that their blood pressure requires progressively higher doses or additional medications over time, because the biology is advancing while only the symptom is being treated. The biological mechanisms driving hypertension in adults over 60 are specific, well understood, and directly modifiable through targeted intervention. They are chronic endothelial dysfunction, systemic inflammation driving arterial stiffness, overactivation of the renin-angiotensin-aldosterone system, causing sodium and water retention, magnesium and potassium deficiency, disrupting vascular smooth muscle relaxation, and dysregulated cortisol patterns from chronic stress, and poor sleep amplifying sympathetic nervous system activity. Every one of these mechanisms responds to specific, evidence-based lifestyle and nutritional interventions, and every one of them continues advancing if the only intervention applied is a medication that lowers the pressure reading without addressing the biological process generating it. A study published in The Lancet followed adults with hypertension over a 15-year period and found that those who combined antihypertensive medication with targeted lifestyle interventions addressing the underlying vascular mechanisms required significantly lower medication doses, had measurably less arterial stiffness progression, and had a 43% lower rate of cardiovascular events compared to those on medication alone. The medication was not the difference. The medication was the same. The difference was whether the underlying biology was also being addressed. This is the correction. Not stopping medication. That conversation belongs with your physician and should never happen unilaterally. The correction is understanding that medication manages the pressure while targeted biological interventions address the mechanisms generating it, and committing to both simultaneously rather than treating the prescription as a complete solution. Here is what addressing the underlying biology actually looks like in practical terms, because this video is not useful unless it ends with specific actions you can take starting today. The first and most impactful intervention is dietary nitrate intake through dark leafy greens and beets. Nitrates from food are converted by bacteria in the mouth into nitrites and then into nitric oxide in the bloodstream. Nitric oxide is the primary endothelium-derived vasodilator. It is the compound that keeps arteries flexible and open. Adults with hypertension have measurably reduced nitric oxide production, and restoring it through consistent dietary nitrate intake directly addresses the endothelial dysfunction that is the root biological mechanism of elevated vascular resistance. A study published in Hypertension found that adults who consumed 2 cups of dark leafy greens or 4 ounces of pure beet juice daily for 8 weeks showed an average systolic blood pressure reduction of 8 millimeters of mercury, without any other intervention. 2 cups of spinach or arugula daily. That is the threshold. That is the dose. Begin tomorrow morning. One critical point that almost nobody knows. Do not use antibacterial mouthwash before eating leafy greens or drinking beet juice. The bacteria in your mouth perform the first step of nitrate to nitrite conversion. Antibacterial mouthwash eliminates those bacteria and reduces the nitric oxide production from these foods by up to 60%. You can eat the greens and receive almost none of the blood pressure benefit if you have used mouthwash within the previous hour. The second intervention is magnesium restoration. Magnesium is the biological calcium antagonist inside vascular smooth muscle cells. When magnesium is present in adequate amounts, it blocks calcium from triggering vascular smooth muscle contraction and keeps arteries in their relaxed, dilated state. When magnesium is deficient, which it is in an estimated 45% of adults with treatment-resistant hypertension, calcium enters vascular smooth muscle cells unopposed, arteries contract, peripheral vascular resistance rises, and blood pressure climbs regardless of what medication is prescribed. A study published in the European Heart Journal found that adults with hypertension and confirmed magnesium deficiency who restored their magnesium to adequate levels showed blood pressure reductions equivalent to those produced by a low-dose antihypertensive medication from magnesium alone. The highest magnesium foods are cooked spinach at 157 milligrams per cup, pumpkin seeds at 156 milligrams per ounce, cooked black beans at 120 milligrams per cup, almonds at 80 milligrams per ounce, and avocado at 58 milligrams per half fruit. For supplementation, magnesium glycinate at 300 to 400 milligrams taken in the evening is the most bioavailable and best tolerated form for adults over 60. The standard serum magnesium blood test does not accurately reflect cellular magnesium status. Ask your physician specifically for a red blood cell magnesium test if you want an accurate measurement. The third intervention is potassium optimization. Potassium and sodium are direct biological counterparts in blood pressure regulation. Sodium causes water retention and vessel constriction. Potassium causes water excretion and vessel dilation. The human body evolved consuming a dietary potassium to sodium ratio of approximately 10 to 1. The modern American diet delivers a ratio closer to 1 to 3, an inversion that is, at the vascular level, a continuous blood pressure elevating signal. A study published in the BMJ found that increasing potassium intake to adequate levels reduced systolic blood pressure by an average of 8 millimeters of mercury in adults with hypertension, an effect comparable to first-line antihypertensive medication produced by dietary change alone. The highest potassium foods are cooked white beans at over 1,000 milligrams per half cup, baked potato with skin at 900 milligrams, cooked spinach at 840 milligrams per cup, avocado at 700 milligrams per half fruit, and cooked lentils at 730 milligrams per cup. Notice that several of these foods deliver both potassium and magnesium simultaneously, which is why a diet built around dark leafy greens, legumes, and avocado addresses multiple hypertension mechanisms at once. The fourth intervention is sleep optimization, specifically targeting the cortisol dysregulation that chronic poor sleep produces and its direct effect on blood pressure. During normal healthy sleep, blood pressure drops by 10 to 20% in a pattern called nocturnal dipping. This overnight pressure reduction gives the cardiovascular system its primary recovery window. Adults who do not experience normal nocturnal dipping, a pattern called non-dipping hypertension, have a significantly higher rate of cardiovascular events than those with the same daytime blood pressure readings who do dip normally at night. Non-dipping is driven primarily by elevated cortisol and sympathetic nervous system activity during sleep, which is itself driven most commonly by poor sleep quality and inconsistent sleep timing.